Good morning, and welcome to Emerging from the Pandemic, the long-term impact of COVID-19. My name is Kimberly Caesar, and I am the head of Global Health at Hackensack Meridian Health. Hackensack Meridian Health is New Jersey's largest and most comprehensive health system. During this pandemic, we have treated over 32,000 COVID-positive patients. Hackensack Meridian Health consists of 17 hospitals and over 500 patient care sites. Today, you will be presented by Laurie Jacobs, our professor and chair for the Department of Internal Medicine at Hackensack Meridian School of Medicine and Hackensack University Medical Center. Dr. Jacobs is a board-certified internal medicine physician and a board-certified geriatrician. She is a former president and board chair of the American Geriatric Society. Thank you for tuning into our webinar. And now, Dr. Laurie Jacobs.
Hello to all of my colleagues around the world. I'm really excited to present today information about the changes in the COVID-19 pandemic that we're starting to observe in patients who are recovering. I'm certain that you have all had a lot of experience with acute COVID-19 in each of your institutions. As patients have begun to recover, we've noticed that many have persistent symptoms. There was a WHO workshop held on Tuesday of this week with testimony from around the world and observations of what patients are experiencing. And it's my goal today to bring you the state of the art in terms of post-COVID-19 associated disease. One of the issues that the WHO spoke about is that we don't actually have a name yet for this chronic syndrome that appears to be occurring in a number of patients previously infected by COVID-19. So my goal today is to describe this syndrome, describe the time frame, the signs and the symptoms associated with post-acute COVID-19, and then try to start to talk about how we assess these patients and hopefully begin to do clinical trials of treatment for these patients. So in the acute phase of COVID-19, which we are still immersed in around the world, as of yesterday, we had 106 million cases, 2 million deaths, and this is persisting. But there are many patients who are now recovering with persistent symptoms, and we want to describe what they're describing, who they are, and perhaps some thoughts about prevention, treatment, and the impact of the vaccine rollout on this syndrome. There are other viral infections that have been associated with late consequences. Late consequences of viral infections can occur because there was initial broad organ involvement in the acute infection. That was certainly the case to some extent with COVID-19, although it hasn't been demonstrated that the virus penetrates the brain. There are syndromes associated with long-term hyperinflammatory states. And then there is a syndrome, the post-ICU syndrome, that we'll discuss, that is purely associated with the care of patients who have been sick enough to require intensive care. And in addition, there are ongoing viral or infectious activity in some infections associated with a host reservoir. That has not been demonstrated for COVID-19. So we have learned some lessons from influenza, from SARS, chikungunya, MERS, and Zika virus more recently, all of which have been associated with chronic syndromes, inflammatory, arthritic, and other syndromes. But COVID-19 is prevalent now worldwide, and the number of people recovering really trumps the numbers for all of these other viral infections, and it's imperative that therefore we understand these syndromes and we can begin to prevent and treat them. So the symptoms of acute COVID-19 infection are listed on the left. This was a publication from Italy in the summer. And on the right, they demonstrated symptoms in patients as early as a month and going up to 2 months that were similar, but to some extent different in prevalence. Since this time, we've identified many, many more symptoms that we see in chronic COVID-19, some of which are new and not seen in acute COVID-19. But I will start with the symptoms that are most prevalent, and that is fatigue and dyspnea. And we'll return to that as we discuss these chronic symptoms in COVID-19. Social media groups around the world have collected patients who are suffering from these syndromes. They've likened them to a long-haul truck driver, as we call them in the US. And so they call this long-haul syndrome or long-haul COVID. I am not particularly fond of that term. I think it's pejorative. But in any event, around the world, there are Facebook groups, Reddit groups, Twitter, there are websites, there's an app, the COVID Symptom Study, that has studies going on around the world to collect data that patients report. And they have produced many reports of symptom prevalence and are bringing patients to being active and trying to get the healthcare system to address their complaints and work on, in terms of research, the underlying causes of chronic COVID-19. So I think that this disease has really brought the public forward, and I applaud them for their involvement in trying to push the science of understanding forward. So at Hackensack University Medical Center, where I'm the chairman of medicine, we undertook a study looking at the patients who had been hospitalized in March and April of 2020, early in the COVID pandemic, and looked at who had recovered at 35 days. We examined both their function, and their quality of life parameters. We enrolled 183 patients. A little more than half were male. That's reflective of the epidemiology of who was hospitalized for COVID. And the demographics are presented here. In our study, we observed the same symptoms that were described in the study in Italy and now have been described around the world in patients who have complained of persistent symptoms from COVID-19. Again, fatigue and dyspnea are by far and away the most common, but there are many other symptoms that turn out to be highly prevalent in patients recovering from COVID-19. These patients had an impact of this disease on their ability to perform physical activity and their activities of daily living. 61% had complaints that their activities were mostly, they were able to do most of their activities, but not all of them. And their ability to walk fast or lift and carry, those kinds of activities requiring greater effort had the most impact. Patients rating their quality of life outcomes as poor or fair were highly prevalent amongst this group. The impact on social relationships, I believe, is due to patients being isolated from having acute disease and after that. So that perhaps is not reflective entirely of their symptoms, but of their living situation. But in general, those that related their general health, quality of life, physical health, and mental health as less than good or very good and excellent were high. So were high and related to their symptom prevalence. So patients relating their general health as very good or excellent had a very low odds of having persistent symptoms. And persistent symptoms particularly impacted daily physical activity and other parameters of quality of life. So this was 1 month after the acute infection. Again, returning to the patient-led research that was obtained from social media, another publication came out early in the spring last year, demonstrating that many patients who had persistent symptoms had those symptoms tail off by 8 weeks. This was an early study of only 640 patients. The symptoms that they report, again, are similar to the ones we've seen, and we're going to probe the causes of these symptoms in greater detail in a few moments. I'm sorry. So the timing of the post-acute COVID syndromes is another topic of debate. The WHO did not come up with a name yet or a time to define what the late sequelae are. I call it post-acute COVID-19, but there may be another name that people describe it. And I generally will accept a patient into our post-COVID clinic that has had symptoms generally for 90 days after their infection or 3 months. In this graphic put forth by one group of investigators, they describe patients from week 4 onwards. Although we demonstrated a lot of patients at 35 days that still had symptoms, as we saw in that prior slide, many patients have recovery by 8 weeks. So I would believe that patients who have persistent symptoms somewhere from 2 to 3 months after their infection fall into this category. And that is going to be defined much more carefully by WHO in the coming weeks. These patients needn't have had a positive PCR test or a rapid test or an antibody test. Many patients had a clinical syndrome that was indicative of acute COVID-19, but were never tested, either because they were unable to get testing or testing occurred too late to identify the viral infection. But they should be included if they had the symptomatology, which unfortunately we've all become familiar with. So we're in the process worldwide of trying to define post-acute COVID-19 patients. It's persistent symptoms. I would posit 2 to 3 months after their infection. The literature uses these various terms for it, and I think we will coalesce around one term shortly. So what are the determinants of acute COVID-19 outcomes? In other words, who has a severe illness and who has a mild illness, and obviously who will go on to have chronic symptoms. So we've all observed that those who are subject to getting COVID-19 include more older adults, and although there were more males hospitalized, it's not clear that there are more males that are infected, and perhaps certain racial groups, but that may be due to socioeconomic factors. But it's very clear that comorbid disease, particularly obesity, plays a very significant role in acquiring COVID-19. And there is some question as to whether obesity or diabetes is actually a risk factor for the post-inflammatory syndrome that we believe this chronic syndrome is due to. Other patients who have altered immune status are obviously subject to COVID-19, and perhaps, though we don't know yet, what the genomics are underlying. In terms of exposure to the virus, the inoculum size, the species, the peak viral titers for a patient, and how much viral dissemination may have an impact on their acute course, it's not clear that those factors have an impact on developing chronic COVID-19. And I think the studies have yet to be done. We believe that chronic COVID-19 is an altered host immune response, and whether the host innate immune response, the underlying immune factors, have a relevance to the post-acute syndrome is not yet clear, but there's a tremendous amount of research just starting in this area. Some are looking at adaptive T-cell responses and the development of antibodies. Others are looking at B-cell function. It is very clear that many of these patients have autoantibodies, but not all of them. And the autoantibodies are not of one type, they are many. Whether there's an impact of age and gender, and whether those who had acute COVID-19 that moved from the acute viral infection into a hyperinflammatory state with cytokine activation, whether that has a role. it's starting to look like there is an impact of metabolic factors in the chronicity of symptoms, getting back to the issue of obesity and diabetes. And we've yet to understand whether early treatments, including plasmas, steroids, and all of the clinical trials, have any impact on chronic COVID-19. All of that work has to be done. And finally, will the impact of getting a vaccine in someone who did have the infection initially mitigate or change the course in terms of chronic symptoms? We don't know. So following acute COVID-19, there are two early post-acute illnesses that I want to describe, but are not really included in these post-acute syndromes that occur later. These occur within the first month and usually do not occur later or do not persist later. One is the multi-inflammatory syndrome in children, or MIS-C. This occurs 4 to 6 weeks after an acute infection, and patients have been found to be IgG positive. Some of them were not known to have been infected with COVID-19, but they presented to healthcare workers with fever, marked increase in inflammatory markers, mucocutaneous disease, multi-system organ involvement, often sparing the lungs, but frequently with GI symptoms and cardiac symptoms. And they look like patients with Kawasaki syndrome. These patients are often treated with steroids and do recover. There's a similar, but not the same sort of syndrome seen in adults, again, in that early 4 to 6 week window. These are adults who present with an acute coronary syndrome due to acute myocarditis, and they may or may not have pulmonary disease, but this would follow the acute infection, which is generally a pulmonary infection, although not always. It could be GI. And it occurs days to weeks after their COVID-19 infection, and they're usually, they're sometimes still positive with their PCR, but they may have antibodies at that point. They again have elevated inflammatory markers, fever, elevated troponin, indicating the cardiac changes with the EKG changes of ST segment elevation consistent with their myocarditis, acute systolic biventricular failure. And this is thought to be, again, an acute post-infectious inflammatory syndrome. We're going to return to this description of myocarditis in just a moment. So moving around the world, in Britain, there was some lab data early on from a post-COVID clinic that was set up in their health system. And in their first 163 patients who were followed for a month and then followed up at 3 months' time, they categorized them by the WHO criteria for severity of COVID-19 illness. And those criteria are basically oxygen use. Mild cases, no oxygen requirements. Moderate cases, oxygen was required, and therefore most of them were hospitalized. And severe cases required high flow ICU care or intubation to provide adequate oxygenation. And they observed that persistent COVID-19 syndromes or symptoms occurred in patients who had mild disease, whose initial infections required no oxygen, in 59% of the patients who fell into that category. This observation has persisted, and what this tells us is that it appears the chance of getting persistent symptoms may correlate with severity of illness, but there is a very significant chance of getting symptoms even in patients with mild disease. Therefore, in the social media platforms where most of the patients have not been hospitalized and have post-COVID-19 symptoms, they fall into this mild group, and this percentage is just based on a small sample. We actually don't know the prevalence in each of these groups at this time. So the longer-term medical consequences of COVID-19 are going to be discussed now in specific regarding each organ system. But I first want to mention the non-specific consequences of having COVID-19 that are similar to patients who were admitted for sepsis due to bacterial pneumonia or other causes requiring often intensive care. The first is the post-ICU syndrome. Secondly, we have observed exacerbation of premorbid chronic conditions such as diabetes. And then thirdly, and very prominently, we've observed a very significant thrombotic state. This may or may not be due to autoantibodies. We believe that this is due to the inflammatory response to COVID-19, not a particular change due to this particular virus, but it's more prevalent in this virus. And thrombotic complications include both venous and arterial complications, venous thromboembolic disease, and also stroke and myocardial infarction. The last nonspecific syndrome is that of the loss of hair, which is a very nonspecific syndrome seen in acute circumstances for patients, not even in illness. Patients who have suffered trauma may have this, as well as patients who have been acutely ill. Because it is such a distressing symptom, it has made this list, although it is not nearly as serious a symptom as a thrombotic complication. In terms of the organ system disease, I'm going to go through those in some detail as we know a little bit, but not a great deal yet about their underlying pathophysiology. First, the post-ICU syndrome. For patients who have been admitted to an ICU due to acute respiratory distress syndrome and survive and make it to discharge, a huge percentage describe their physical function deterioration and spend months to years in rehabilitation trying to regain strength and function. In addition, many report cognitive losses. This also improves over time, but can persist for a great long time. And then in addition, psychiatric issues, including post-traumatic stress disorder, anxiety, and depression. We are certainly seeing this in patients who have been admitted to the ICU. The studies of post-ICU syndrome have been prevalent for a decade, and it's clear that early mobilization, lighter sedation, more orientation are beneficial, but it is a long haul to bring patients back to their prior level of function after they've spent time in the ICU, whether it's from COVID-19 or another cause. So post-acute COVID-19 syndromes can be divided into all of these organ system illnesses. That being said, these all must have a unifying pathophysiology that involves probably vascular damage, endothelial cell damage, and leak, inciting some kind of allergic, maybe autoimmune response that then involves many, many organ systems. And it's not clear that these are organs that were initially infected by the virus. As I mentioned before, the virus generally has not been found to cross the blood-brain barrier. So let's discuss these in a little bit of detail. Pulmonary disease with COVID-19. This was the presenting complaint. On the left is the acute syndromes that we see: pneumonia, hypoxia, respiratory failure. Months out, we are seeing patients who continue to have disabling dyspnea, even in the face of improving imaging findings as shown below, and in the face of improving pulmonary function tests. Many patients who complain of dyspnea have a decrease in their DLCO on pulmonary function tests, but not quite as severe as would be accounted for by their complaints of dyspnea. They continue to have interstitial lung disease, but again, not as severe as their symptoms might indicate. And in terms of their function, we measure that on a 6-minute walk test, and their function is quite impaired months out. The second large class of patients are categorized, I believe, by this syndrome that was described prior to COVID-19 and has two names. The neurologists call it myalgic encephalomyelitis, and the internists and others call it chronic fatigue syndrome. The symptoms are chronic fatigue and post-exertional malaise. A patient goes to do physical activity of some sort. You've decided to walk a distance, do the laundry, whatever it may be. And following that, even up to 24 and 48 hours later, they are hit by tremendous fatigue that wasn't as severe before the exertion. The fatigue they describe waxes and wanes. They may be feeling terribly fatigued, can't get out of bed for a period of a couple of days, and then it lightens and they feel better. And then they describe it coming back like a game of whack-a-mole. Bam, they're again very fatigued and exhausted and can't do their activities. In addition to this physical fatigue and malaise, they also describe neurological or neuropsychiatric symptoms of insomnia, pain, problems thinking and concentrating, and dizziness. And those symptoms we see in these other COVID-19 syndromes as well. All of this results in a functional impairment and, in some circumstances, an inability to return to work or participate in your prior level of function. There's a physician in the United States who's been on videos and presented in many conferences. He was an emergency room physician. Never thought that this would be him, but he is unable to function in the emergency room. He can no longer do his work due to this chronic fatigue syndrome. The prior description before COVID-19 was that this occurred in middle age, in women more than men. But the demographics are vague, the definition was vague, and there were very few patients categorized. Those that have these symptoms with COVID-19 are far outweigh in terms of numbers those that were prior. It had been associated with EBV, with other viral infections, but it was unclear prior to COVID-19. And most patients were basically undiagnosed. No one knows the clinical course, whether these symptoms will abate, whether there will be a treatment, and what is the pathophysiology. I want to move into a discussion of cardiac disease, but again, these organ systems, although they appear to be separate and patients may have symptoms predominant of one organ system and symptoms that are most difficult for them, they often complain of lesser symptoms in another organ system that are listed here under another category. So in acute COVID-19, we saw shock, arrhythmias, thromboembolic disease, cardiac infarction, coronary disease, and myocarditis. Myocarditis, we'll discuss a little more in a moment, is also perhaps an intermediary, maybe not a chronic syndrome. We're not sure yet. Secondly, dysautonomia or Pott's disease, again, a syndrome with two names, depending on who's naming it, is highly prevalent. And thirdly, chest pain syndromes and cardiomyopathy. So myocarditis was identified in this initial article by Puntman from Germany, where he looked at 100 patients that had no symptoms and did a cardiac MRI and biopsied those with evidence of acute inflammatory disease and identified that in his sample, 60% had acute myocardial infarction. I want to say this was not randomized, this sample, and it frightened everyone. Following that, there were a bunch of autopsy studies of patients who died from COVID-19. And amongst those autopsy studies, after a final review and a meta-analysis of all the autopsies, the prevalence of myocarditis was less than 2%. So it is unclear how prevalent myocarditis is in the recovery phase of COVID-19 and whether it persists. But it is clear that some patients have acute myocarditis and all of the symptoms that you're familiar with in viral myocarditis from any other cause. This raised a great concern for student athletes who, in the United States anyway, undergo some sort of preliminary medical clearance before they are allowed to participate in athletics at a university or professional athletics. And after COVID-19 appeared, there was some concern about when these athletes could return to activity. Myocarditis was the great concern, as it can cause sudden death in athletes. And there was one study early on that received a lot of press, looking at students who had undergone cardiac MRIs, which is not part of the standard clearance evaluation. Following this study, which demonstrated out of 26 students, very small sample, that 8 of them had had old injury and 4 of them had myocarditis, there's been a lot of discussion in the cardiac literature about appropriate testing for athletes. Whether we should be doing MRIs or echocardiograms, it's still unclear. They do undergo a physical exam and assessment. In general, our advice at this point is this sort of assessment and start low, go slow, increase physical activity slowly initially. Don't go from 0, being ill with COVID, to running marathons just because you did the week before COVID. These individuals have to slowly increase activity to determine safety until we understand these syndromes further. The syndrome of autonomic dysregulation, or called by the cardiologists postural orthostatic tachycardia syndrome, it's a mouthful, but we call it POTS syndrome, is highly prevalent in the patients that we've seen in our clinic and some of the reports that we're seeing around the world. This again was a syndrome described prior to COVID-19. It was poorly described. It isn't that prevalent, but now after COVID-19 in our chronic clinics, a number of patients have complaints of palpitations or tachycardia when they're measured, their heart rate is greater than 30 beats per minute over their baseline, and it persists. So as they go through their day and their activities, they have constant complaints of tachycardia. They also have orthostatic hypotension, and you might think that the tachycardia is in response to orthostasis, but the orthostasis in general can be relieved after a period of time of being stood up. And the orthostatic symptoms obviously are relieved by lying down, are treated in the way that we treat other causes of dysautonomic orthostasis, like with Parkinson's disease, fluid loading, fludrocortisone, compression stockings, etc. And oftentimes we're trying beta blockers for their persistent tachycardia if they are symptomatic. Obviously, that can be challenging in the face of their orthostasis. These patients complain of chest pain, palpitations, lightheadedness, blurred vision, shortness of breath, and all these other symptoms that we're seeing in the other organ systems: headache, nausea, fatigue, tremulousness. If you have a patient with these symptoms, you still have to rule out all the other causes of autonomic dysfunction or orthostasis or tachycardia, including neuropsychiatric syndromes, pain, caffeine, alcohol, hyperthyroidism, etc. One additional complaint that we're going to discuss more is cognitive dysfunction, which is generally not seen. Perhaps it is seen in hyperthyroidism occasionally in older adults, but generally not seen with these other syndromes. So let's talk about that cognitive dysfunction. Acute COVID-19 can be characterized neurologically by patients who have anosmia, they can't smell or taste. They may have an acute confusional state or encephalopathy or delirium, stroke, meningitis, seizures. They may develop Guillain-Barré early or late, just post-acute, and have, there have been cases described of Ondine's curse where they have respiration cease due to neurologic causes. However, the basic science that has been done in this area don't provide any evidence of direct viral entry into the brain. And the post-acute COVID syndromes, patients complain of a persistent sort of non-specific headache. And that's thought to perhaps be a continuing encephalomyelitis. They have, again, complaints that are similar: chronic fatigue syndrome, myalgic encephalitis. They also complain of cognitive impairment, the so-called COVID fog. And in the WHO conference this past Tuesday, one young woman who is working for one of these social networking groups described her own course, saying that after she had COVID-19, she couldn't function. She wasn't able to use the computer. She wasn't able to work. She couldn't perform in her activities of daily living. This was a 30-something-year-old young woman who was in a fog. She had significant cognitive impairment. Perhaps it was a chronic delirium. Perhaps it was just focused in certain areas of cognition, but she did improve and return to baseline. Many patients complain that they have not improved months and months later. We discussed stroke previously as a thromboembolic complication, not a specific complication, but nevertheless can occur post-hospitalization. Others have peripheral nervous system issues, neuropathy, or central Guillain-Barré syndrome, and then neuropsychiatric syndromes of anxiety, depression, post-traumatic stress disorder, insomnia, and again, dysautonomia. We've seen renal disease in acute COVID-19 that is very severe, and in patients who had prior chronic kidney disease, but in many patients who had no history of prior chronic kidney disease. Many patients who were in the hospital, particularly those in intensive care, had evidence of tubulointerstitial disease, glomerular disease, vascular disease, and these were perhaps the impact of the acute infection. You sometimes see this with hepatitis virus and other viral infections, but they also, if they had gone on to the inflammatory phase, the second week of the acute infection, had damage due to the cytokine storm. They may have had clotting, as we've described, and they certainly had immune activation and probably deposition causing renal disease. So at discharge, in one study, 31% who were on renal replacement therapy were new, who had developed renal dysfunction in the hospital from COVID-19. Of those people, a third of them have persisted to have chronic kidney disease, many of whom are remaining on renal replacement therapy. 20% have now persisted to require dialysis chronically. Very labor, time, and expensive therapy for patients and for health systems. In addition, we're seeing a significant number of patients who are complaining of GI symptoms months after COVID-19, diarrhea being the most prevalent symptom. Some of them, the diarrhea appears to be an inflammatory component. Others seem to have new C. difficile infection without having had a prior course of antibiotics or obvious risk factors for C. difficile acquisition. Is there a change in their native biome in their GI tract due to COVID-19 infection? I don't know, but there's tremendous investigation as a mechanism for these syndromes now in that area of the biome. There is liver disease that was seen in acute disease, and some of those patients have persisted. And finally, in terms of endocrine disorders, it's been observed that patients with type 2 diabetes have had worse outcomes from their acute infection from their acute infection with COVID-19. And there has been a hypothesis that stress hyperglycemia may have a role in producing these chronic COVID-19 syndromes. Remember, we mentioned in the beginning, patients with obesity and patients with diabetes were at very high risk for acquiring COVID-19 infection. The question is, are those patients also at risk for these syndromes later due to the impact of hyperglycemia? In addition, we're seeing the new onset of diabetes in patients who have these various complaints of COVID-19 chronic persistent symptoms. Not surprisingly, we're also seeing thyroiditis. That's often seen in post-viral infections. It's not particularly different with COVID-19. Finally, rheumatologic complaints. I leave it to last because we have the most difficulty characterizing these syndromes in general, but patients are complaining of joint pain, fatigue, and fatigue to a rheumatologist looks like fibromyalgia. To a neurologist, again, myalgic encephalitis. To an internist, chronic fatigue syndrome. This all may be one. We're not sure. There are patients who have vasculitis, acute and chronic, and we do believe that endothelial cell injury is part of the pathophysiology of COVID-19 causing acute and probably chronic disease. It's been observed, as I mentioned before, that autoantibodies are found in patients with chronic symptoms, but not one particular autoantibody has been most prevalent. So we've seen anticardiolipin antibody, antiphospholipid antibodies. Clearly, those are associated with thrombosis, and so those were looked for. But many autoantibodies have been found. And to many, these symptoms look like an autoimmune phenomenon and are looking for other autoantibodies. Finally, there are cutaneous manifestations that we are seeing in our clinic months after infection, various rashes and vascular lesions that were either seen in the acute disease or can be seen even after their acute illness is resolving. So, who has chronic COVID-19 syndromes? Well, we've heard about these symptoms and syndromes from social media, from the medical literature, from reports of hospitalized patients, which have a male predominance since more men were hospitalized than women worldwide and in the US. There is no community-based study to demonstrate what the epidemiology of this infection is. That is one of the major goals for the NIH in the US and the World Health Organization. We have to understand, first of all, how prevalent is this problem and in whom are we seeing this? Most of the studies currently have a tremendous bias. They're looking at patients either who had access to health care or reporting anomalies from academic medical centers or resided in a certain region or had different socio-demographic circumstances. Most of us in this area, however, think that this has a prevalence particularly in middle-aged patients. We're seeing it more rarely in younger patients, more rarely in older adults. I'm a geriatrician. They may have the impact of having an acute, serious illness, but these particular syndromes seem somewhat less common, although I don't know that yet. There is also some suggestion that there's a female predominance, which wouldn't be so surprising if it's an autoimmune phenomenon, but that has not been demonstrated yet either. Additionally, the early data shows that these syndromes are seen across all severity groups, probably, but not with great certainty, more prevalent in those who had moderate or severe disease. So we've got a lot of work to do. We've got to figure out who is at risk, what causes these syndromes, how to prevent these syndromes, whether they were impacted by vaccines and early treatments, and finally, how to treat the millions of individuals who have had COVID-19 and now are presenting with these symptoms. My guess is it will be somewhere in the 2 to 10% range of patients who initially had COVID-19 infection, but even 2% of the world. Remember that first number that I gave you of infections as worldwide as of yesterday would mean an enormous number of patients suffering from chronic COVID-19. And I want to reinforce that probably the risk factors for developing acute COVID-19 are different than those for developing chronic COVID-19. Acute COVID-19, we know obesity, age, etc., are highest risk factors. So what do we do about assessing these patients? Well, I think it's very important to collect complete data, because when we start to have clinical trials and therapies, we need to understand our patient's experience. So you need to know when their acute illness started, what was the clinical course? In other words, was it self-limited 1 week long, or did they go into the inflammatory phase and have lung disease, or was it completely GI disease? You need to know those initial factors. What are their comorbid conditions? Diabetes, heart disease, and additionally, what treatments were given during their acute infection? Many trials of treatments were undertaken. Most were not found to be efficacious, but it's clear that patients with the inflammatory phase who were treated with steroids had a better outcome. Steroids were used widely at the beginning. Now it's thought that they should be not used in the early phase, but in the second week in the inflammatory phase of the acute illness. Did that early steroid treatment prevent chronic symptoms or not? What is its relationship? Additionally, the other modalities of treatments, have they had an impact? We don't know. We need to understand the patient's social history, as these syndromes can be disabling, and we need to assess them often in terms of their ability to return to work and also to live in their own home environment. If a patient lives in a building where they have to walk 1 to 2 flights of stairs to reach the bathroom or their bedroom, they may not be able to do that. So it's important to get a full social and environmental history. Next, it's critical to assess their physical function. You should do a complete examination, obviously, do vital signs, a pulse ox. And when I say vital signs, I think you should do orthostatic vital signs, a full physical, particularly important to do a neurologic exam and to do a functional status exam. A functional status exam can be a get up and go test, which is used in geriatrics. It tests proximal muscle function and other functions, but also in patients who are complaining of functional disability, it is worthwhile to do a 6-minute walk test. In addition, one should use standardized instruments. You can use screening instruments, but you should use some standardized instrument to assess their cognition and emotional status. Worldwide, there are many different cognitive tests that are in use, but I would advise trying to use at least one and do further neurological and neuropsych testing in those who fail those initial screening cognitive tests. That will also be part of their assessment in terms of returning to work. In terms of laboratory testing, we're of 2 philosophies. If you're going to engage in research or enroll patients in clinical trials, you should probably test broadly. If not, probably you should test more specifically related to their symptom complaints. But at baseline, one would want to check their blood count, renal and liver function, inflammatory markers. If it's early on or they have any cardiac symptoms, troponin, urine testing, perhaps imaging. We have a very low threshold for doing lung function studies since dyspnea is incredibly frequent, and you don't want to mistake a reversible asthma from a viral infection for interstitial lung disease that's not irreversible. So the lung function studies are very helpful in the diagnosis, in a more careful diagnosis of dyspnea. That said, advanced imaging studies such as CT scans, MRIs may be undertaken. Most of these patients have resolution of their imaging findings, although there was a study published in the New England Journal that demonstrated using much more fine cuts and specialized software that vascular changes were prevalent throughout the lungs of patients whose imaging studies had returned to being read as, quote, normal. What can we do short of enrolling patients in clinical trials? Well, I think weight management is really important. It has an impact on all of function. If they're smoking, obviously that needs to be addressed. We need to help people actually sleep. Insomnia is incredibly prevalent in these patients. And we need to advise them about exercise and provide emotional support. We need to manage chronic diseases. As I mentioned, diabetes appears to be worsened in patients who have had chronic COVID-19, and hypertension was a prevalent risk factor. We need to manage their medications. Some are given all kinds of experimental treatments for this that have been shown not to be beneficial. We need to take a careful look at what they're taking, and monitor their function, refer them as needed. This is all short of having clinical trials roll out, which I do believe will be very soon. One thing that we do offer is rehabilitation, and there was a published article just this week showing the beneficial effect of pulmonary rehab and also separately regular physical therapy rehabilitation for patients who have persistent fatigue, dyspnea, and exertional fatigue. Pulmonary rehab is intensive rehabilitation training and position training, respiratory resistance training. Physical therapy is of benefit in addition for those, also cardiac rehab for those who might have POTS syndrome. Many patients need psychological assistance, pain medication, and further physical therapy. So what is the road ahead? We need to develop a nomenclature for these syndromes. We need to define their pathophysiology and their mechanism of disease. What's involved? Is it the receptor? Is it the virus? Are there animal models for this? What is the natural history and clinical course of these syndromes? Who is particularly at risk? Is there an underlying biomarker or genetic marker? Can we pick it up with blood testing or imaging? Which host characteristics put patients at risk? What is the role of immune modulators, vaccines, anticoagulants, steroids? And then we need to identify which patients should be studied and what studies should be undertaken. We need to engage the community in this research. I think they're highly motivated from the social media sites. And we need to develop care and treatment protocols. So at this point, I'm going to give you our global health email address. If you have further questions that you want to send, they will forward them to me. And I'm going to entertain questions. If you would put them in the chat box, I'm going to switch my screen now to be able to look at the chat box and answer your questions. So someone commented that they think that COVID has all kinds of cardiac problems plus myocarditis, and it's due to immunity. I would say that I think myocarditis is probably an early syndrome, but there's immune damage to the heart and also damage from thrombosis that can worsen underlying cardiac pre-existing disease as well as in other patients. And there is a high prevalence of cardiac disease. So I think we need to be more aware of patients who we would ordinarily say have a low pretest probability for cardiac disease that walk into our office with a chest pain syndrome. There are many patients with chronic COVID-19 who complain of chest pain. Some of it sounds like cardiac disease. Some of them have pleuritic chest pain, and some of them are having chest pain because they're so dyspneic. Their chest muscles are giving them pain. Another question is there a carrier state for SARS-CoV-2? Could vaccinated individuals become carriers? That is a whole other topic. It is observed that some patients still can be PCR positive, retain viral fragments in their nares, in their nose, and we don't know if they're infectious. We think not. We don't advise getting PCR testing in these patients with chronic COVID syndromes. In terms of vaccinated individuals becoming carriers, that is a whole separate topic from chronic COVID-19, and there was one breakthrough article on this suggesting that those who were vaccinated in one country with one of the vaccines had a much lower rate of carriage, but we need further studies to know that that is really true. Another question, is there a recommended long-term medication management protocol for those recovering from COVID-19? No, there isn't. We don't know actually how to treat these patients. If it's an immune dysfunction, should we be using immune agents? If it's due to further vascular or thrombotic disease, should we be using anticoagulants? Steroids are clearly dangerous to use indiscriminately for patients. We don't know how long, what dosage, or whether they help. I do believe that there will be organized studies through the WHO and through the NIH in the US. I have never seen such focus because of the large number of patients and collaboration in this area. I think you will see suggestions coming forth in the literature, and I may redo this lecture, in 2 months and have much more to say on that topic. Moving on, someone commented, we have few COVID-19 vaccines administered to the public, which have the best results. So that topic is outside of the discussion here. However, I would say whatever vaccine is available to you, that's the best that you can get, and you should take it. I don't think at this point there's enough vaccine available worldwide everywhere that we can discriminate and pick and choose which vaccine, unless you're the country purchasing the vaccines and you're making a choice. Is there a role for steroids in the treatment of long COVID? I don't know. I surmise that perhaps there might be. However, I don't think long-term steroids are safe. They bring a whole host of other problems that everyone is familiar with. There may be other immunomodulator drugs that will be much safer and more effective than steroid therapy. Colchicine, someone mentioned, and that is one area that is under study. I have no opinion at this point because there are no results. The prognosis of multi-inflammatory pediatric syndrome, if treated, is generally good. Someone asked about that. Are there connections between COVID and other viruses such as EBV? If you're asking about co-infection, we don't think so. We have not even seen much co-infection with influenza, at least in the US. That said, some of these syndromes we've seen with EBV, chronic fatigue syndrome, etc. So there may be some sort of similar immune response to the viral infection, but the breadth of syndrome seen with COVID-19 appears greater, and it's difficult to know, but I don't believe it's due to co-infection. Someone also asked, is there any role for gut biome in parthenogenesis of COVID? We are looking at the gut biome, worldwide, whether that has a role in terms of being a risk factor or being resistant to initial COVID infection, whether that has a role in chronic COVID, whether there's a role for treatment. Further than that, I really can't comment. I don't know the results yet, but there will be data in the literature. There are people looking at that. Someone asked how to manage post-COVID fibrosis and hypooxygenation. I think in the same way that you manage it in every other patient who might have hypoxia due to other disease, oxygen therapy, pulmonary rehab, see if there's responsiveness to bronchodilators, etc. There's no magic bullet yet for this, unfortunately, but maybe there will be. And finally, is it safe for long haulers to get vaccinated? So again, there's no literature, but the recommendation is that people who have had COVID-19 infections get vaccinated sometime later, maybe 3 months after their initial infection. There is some discussion now worldwide that perhaps those individuals, if they're going to get the 2-dose vaccine, maybe should get 1 dose instead of 2 doses. It should have a booster effect, but others there's no data to drive that. So I'm not recommending that. I have no recommendation. I think there will be a literature on this shortly, but there is not at the current time. I thank you all for your attention. It's been a pleasure speaking with you today. I hope that there'll be much more information to answer your questions in the coming months. You're not going to stop hearing about COVID-19 and post-COVID syndromes for quite a while. Thank you for your attention.